Everything's ongoing, so I'll start. Good evening, everyone. Welcome to one more webinar for BJAN, our fourth webinar for 2024. Today, we'll speak regarding perioperative care patients with dengue, not just for Brazilian anesthesiologists, but also outside of, it's an epidemic in several places in the world. So it's important not just for Brazilian anesthesiologists, but those of you that are listening, hearing us outside Brazil to understand a bit more about the challenging care for these patients. And today for this event, we will have the pleasure of counting on a moderator, Dr. Plinio da Cunha Leal. Dr. Plinio, he is a professor for Maranhão, anesthesiologist of São Domingos and São Luís, and top of being the director of the scientific department of the Brazilian Society, a member of editorial council. Before we let Plinio moderate the event, we have the illustrious presence in our activity, which is the president of the Brazilian Society, Dr. Diego. Make use of the word for a few moments, and after that, Plinio, you can start the presentation and moderation of our webinar. If you would please, Dr. Diego. Thank you so much. I'm here especially to congratulate the work of BJAN does this webinars, and also the presence of our directors here, Dr. Plinio, Dr. Lorena, Dr. Liana participating. It's a very important subject generated this publication. Congratulating all of you, especially Dr. Lorena. She will have a presentation, and also Dr. Plinio, also moderation. For you, Andre, it's great to count on you as editor-in-chief of the Brazilian Journal. Plinio, go ahead. Good evening, everyone. We will continue these BJAN webinars very well led by Dr. Andre, just increasing the impact factor. It's something that's been ongoing for some time now. So thank you so much, Andre, for your partnership. Mel, she always cares so much for BJAN. And also counting on Dr. Lorena, she'll be speaking about perioperative care, dengue patients. She is one that led this project and this article, which will be discussed now a little bit in this webinar. Good evening, everyone. Dr. Lorena, go ahead. Thank you, Dr. Plinio. Thank you, everyone. I will share my screen now. One moment. Let's begin with, I would like to, sorry, can you see this? Can you hear me? First off, I would like to thank you for the opportunity of presenting this editorial about anesthesia and perioperative care management in patients with dengue. I have a few considerations, and we'll see what countless challenges we have. This is a team job, and our team, we have Lorena, Dr. Liana, Dr. Plinio da Cunha Leal, Dr. Michelle, Dr. Diego, and also Dr. Andre. Everybody worked really hard on this project. So, to speak a bit about dengue itself, dengue is an arbovirus. It's the first report in dengue is from 1779. It's from Flaviridae family, looks like yellow fever, Zika, and chikungunya. It shares a bit of the genome on a few clinical manifestations. There's 4 serotypes. There's 1 to 4. 2/3 of the genome are in common, and well, there's a few differences that cause differences on its form of presentation, the way the vector is the Aedes aegypti mosquito, which is present in 128 countries. There's an at-risk population of almost 4 billion people, 53% in 2015, and it tends to increase more and more with global warming. It is a illness located generally in tropical and subtropical regions. Most of them are developing countries, South America, Central America, part of Africa, and South Asia. Has an economic impact that is huge of $8.9 billion. Despite all this, despite the size of the illness epidemiologically, the literature about surgical patients with dengue is very scarce. This is what motivated us to study a bit more about this. In Brazil this year, this is the map up till May of this year. In the dark blue, we could see here the current year map, and in the light blue, last year. So we see that there's a boom
até 4 vezes mais casos do que o ano passado no mesmo período, gerando
during a
mais
time period generating more than 2,000 deaths and a lethality bordering almost 5% of serious cases. The most prevalent states were this Middle West states, Midwest states, the southern region as well. They had the least prevalence than other years, and the northern region as well, focusing on the Federal District, Paraná, Espírito Santo, Santa Catarina, and Goiás. So we had this editorial with the goal of updating the clinical findings, the diagnosis, a dengue classification, and I was trying to revise to see what the literature shows us as evidence, the perioperative management, and also how to manage critical patients with dengue that a lot of time reach our hands. So this is the QR code for the paper. It's open access for everyone. So what was our strategy? Was to have a revision. We had a systematic revision, crossing the terms dengue with anesthesia surgery, clinical complications, perioperative care management, post-op care, pregnancy, and intensive care. This was a revision up till April the 13th, about 2 months ago, and the database. We use a very wide-reaching database. We realized that a lot of papers, they also were in Spanish, so it was important for us to include this in the database. So we found 46 more relevant articles that we brought to this editorial. So about dengue itself, it's important for us to understand how it installs itself and what are the phases. There is an incubation phase of 3 to 10 days. After this period, it can install into the feverish phase. Most people, actually, about 80%, are asymptomatic, and only 20% installs themselves in the feverish phase. It's a sometimes low, moderate fever with a feeling of fatigue, pain in the back of the eyes, and it hits about 50% of people. But most people here, they go straight to the recuperation phase. Others go to the serious form of the illness. About 5% get to the critical form. In this critical phase, we have a reduction of leukocytes and blackheads platelets. We understand this somatic symptoms associated to leukopenia. And this phase is after the fever phase. The feverish phase, as the name itself, is a fever. And after the fever passes, those are the most critical 2 days of the illness. It really is the serious phase. After this phase, you can have convalescence, where there is a reabsorption of these liquids in around 72 hours. So it's very important for us to monitor, as you're seeing in the red, the hematocrits to understand the base value for every patient hematocrit, and then it will increase in the critical phase, goes to the epics, and it goes to the convalescence phase. This coincides with the plasmatic transition. There's a certain hypovolemia and an increased hematocrit. So this coincides with the nadir of the platelets. They'll reduce to the lowest value, coinciding with this high hematocrit value, and then the platelets once again return to their normal values. So the way we will research on dengue will depend on the phase. Patients at the start of the illness, the first 3 to 6 days, will study the virus itself, ATC-PCR, or more simplistic research, which is the antigen, which is very specific and sensitive, NS1. And then after six day, we got the IgM. After a second week, 10 days, the IgG. If the person was infected, the first infection was infected by the second time, that there is an alteration in this form of presentation during diagnosis, where I have the GGG, the IgG value at the highest at the start of the fever phase, and then it can result into a more serious form of the illness, and the gravity, the seriousness. Classification was reviewed in 2009 in the WHO. Nowadays, people say, oh, okay, this person had dengue shock syndrome or hemorrhage thing. But this classification was removed by the WHO. It seemed that it ended up simplifying things in a way for these patients to be able to be admitted more quickly into the ICU and to be put together with patients that could go to a more serious form. So what is the newer patient, just so to speak, more serious from 2009? The first patients are the ones that are non-alarming patients with a light illness, dengue, that is most people will go through. And then there are patients that are in this phase where they develop some alarming signs. These signs are very important because they will be a predictor, provision of whether it will go on to a more serious stage or not. These patients that have abdominal pain, persistent vomit, accumulating fluids, hemorrhage, intense lethargia, a certain drop in body temperature, I have an increase in the hematocrit and the reduction of platelets. These people can evolve to a serious form of the illness. We need to keep an eye on these people. So one form or the other can evolve to a serious dengue. That's 5%. What defines, which is plasmatic, well, there's bleeding and organic dysfunction. This goes for three organs: the central nervous system, the liver, and the heart. So what are the risk factors for people that are more predisposed to have a serious form of dengue? There are the factors related to the host. These people, we need to be more attentive. These are children under 1 year or the elderly above 60.
Pacientes imunodeprimidos é que eu vou chamar a atenção dos transplantados, diabetes, hipertensão,
diabetes, hypertension, heart patients, obese, malnutrition, asthma, EPOC, and kidney disease, and a few genetic factors. People that are of African descent, they are more perfect in polymorphisms. I will not go into detail. Very important. People that have already had dengue once, when they get the illness for a second or third time, they also tend to have the serious one. If this interval, the second one and the second was very long also, and the exposition to water, flavivirus, or the yellow fever, etc. Immune factors, that serotype, it's also predisposed towards the seriousness. The NV2 is more serious than the American ones, and the earlier phase of the viremia. But we can see that people are transiting globally between countries, and these forms end up getting mixed up. The physiopathology is very complex. I'm not going to go into much detail, but at the start, when the virus is inoculated by the mosquito, we see these yellow circles. That's the virus. They will infect blade and dendritic cells. So on the blood flow, it will go to the macrophages, and the macrophages will release these small particles called virins, which are these NS1 proteins. These proteins would call the rip of the plasmatic leakage. They will break the calx endothelium. They break the endothelial layer, and this will cause a serious degradation of platelets through several mechanisms that I will not go into detail with. What's sure is that all these manifestations cause a boom on the immune system, a cytokine storm, and they attack a few systems directly, the central nervous systems, Several people can encephalitis was the most feared form of this illness, and the hematological thrombocytopenia. There's platelet dysfunction. It's not just production. And the medulla is also suppressed. It also works on the function, low fibrinogen levels, and there's an imbalance of the fibrinolytic system in the cardiovascular system.
Como por exemplo,
Have arrhythmias, BAV. There's alterations on the ST segments or several arteries of myocarditis. The more serious one of all, there's congestive heart failure and others, like the ones that attack the liver, because the virus attacks the liver directly, causing apoptosis on the hepatocytes, and there's a trend towards an acute liver failure, a serious, very serious. It also attacks or directly or indirectly the kidney. It can be gastrointestinal bleeding. It's very common, and a few others that we'll see further on. It's very important to understand that dengue can predispose towards malignant hyperthermia in susceptible patients. And during pregnancy, we need to be really careful because it can cause miscarriage or preterm birth. There can be risk for the fetus, and it can also predispose with preeclampsia, eclampsia, and cause hemorrhage in cesarean procedures. We'll see more about that. So what is the role of dengue in perioperative care? We need to understand that there's a number of alterations, microvascular, there's plasmatic leakage, there's a complete lack of function of our immune system, a cytokine boom, there's alterations, and blood clots. So it has a whole influence when a patient will go through surgery. So these patients, they have and basically a neuroendocrine responsive trauma and the systematic bleeding and shock and other complications as well. So we need to understand the illness to be able to treat these patients, especially critical patients. On top of that, they can have acute abdominal syndrome. It can be a real cause of acute abdomen or a case for the dengue simulates acute abdomen. They can end up going to a laparotomy, surgery, and actually they didn't need to go, and they end up having the whole effect of neuroendocrine response. So in this review article, one of the best that we found relating to surgical patients, it brought us 22 studies, more than 9,000 patients with a dengue, and it's a 16% incidence of acute abdomen. More than 1,500 patients with acute abdomen. Only 20 of them went through surgeries, showing here that the most conservative treatment in these cases sometimes has a better outcome. So what were more the frequent cases? So pancreatitis, acute appendicitis, perforation, peritonitis, and specific peritonitis. So this leakage that happens because of dengue, it can cause a edema and cause cystitis or calculus or the translocation of bacteria or favoring appendicitis, and also hematoma. It can also cause wall hematomas or splenic hematomas as well. So it's very important to pay attention to this abdominal pain and the management of the preoperative care. So if I have a patient with a suspect of dengue in the perioperative care, I need to confirm this according to the phases, clinical phases that we saw beforehand. I need to identify the patients with a risk factor of dengue that is more serious. It's those that we pointed out as well. And if the patient has acute dengue, I need to assess how many days he's had dengue for, at least the symptoms, the clinical phase they're on, if there are alarming signs or some sort of organ dysfunction, also assessing the urgency of the case. Of course, if it's urgent, I need to keep going, but if it's elective, we will try to see how we behave to be able to delay the surgery and do it carefully, safely. So also the full blood test battery is very important for us to see the base value of this hematocrit and this blanket in patients with dengue, but you also need to assess as a whole all those systems that were attacked. The patients that sometimes arrive from an ICU, they have a lot of information. There's a valley here for the ultrasound. There's two of them. They will visualize pleural effusions that can be very useful since we're going to manage clinically the replacement, fluid replacement. We also see seriousness markers, albumin, a lot of patients that hypoalbuminemia, and it's related to the seriousness of the illness and the perioperative vaccine. We're on a phase where everybody's been talking about, okay, I want to vaccinate. We got the vaccine. It's being offered, right, by our public health system. In Brazil, the vaccine that we have currently is the Qdenga for dengue. It's approved currently. We have two of them. Then vaccine Qdenga, both of them are tetra, are four types. But there is no consensus on how to vaccinate patients that were vaccinated pre-operative. So for patients that were vaccinated for the live virus, there's only one specialist opinion. You need to wait 3 weeks until you can operate on patients. But since we're talking about transplant patients or patients that will go for an splenectomy, for instance, they need to go for the surgery. So we'll try not to bother the surgery time. Here, I will show you a few cases that we found for us to be aware of the degree that dengue can affect a surgical patient. So a transplant patient in a Fortaleza hospital, they mentioned two cases in the third DPO, one from platelets, fever, acute renal lesion. One of them actually passed away. These patients were patients that they got their surgery. The one that I'm going to show you, they got their surgery and then they evolved the post-op. They had fever, platelet, like a platelet. So after being operated by the elective surgery, a reconstruction surgery as well in the second DPO with a lack of comfort. And this is interesting that it showed on these charts an increase in hematocrit coinciding with the drop in platelets. And you can see that the alterations started more or less on the fourth day of post-op on patients of bypass patients, cardiac vascularization. Also on the third PO, patients for nephrotoxic manifestation, the second PO, and patients went nephrotoxically percutaneous on the second, third EPO. These are not the patients that I'm mentioning. Some of them has moved on, someone passed away, others managed to make it. But it's in the most acute period of the post-op is that these patients will have that cytokine boom associated to surgical trauma. We need to pay attention to patients that are fevers in the post-op and endemic regions also need to think about dengue. So seeing the seriousness of this, we made a suggestion for elective surgeries. It's very clear that a patient with dengue in an acute phase, they must have their surgery delayed, not canceled. It will happen. And in the light patients with light dengue, we suggest to wait for 14 days. The patient group that have risk factors I have alarming signs to wait for 3 weeks, and those patients that have serious dengue, there is no provision. But important thing is that this patient that they must have all the release criteria for dengue during surgery. They must not have a fever. They must have good appetite. A hemolytic case, the bleeding index. You need to observe the bleeding index, and you need to keep an eye on the blood exams, the exams of these patients, especially platelets. So if the patient gets the intraoperative care, there's a few things that we must take care of, especially when it comes to our airways. They tend to have edema and the breathing airways, so maybe a difficult airway there can be bleeding when it comes to manipulating the airways. It's very serious, and bleeding on the gastrointestinal tract and the airways.
Sangramento de mucosa também. É um risco de aspiração naqueles pacientes que estão em vômitos em
Patients that are vomiting, you need to remember that dengue shock is hypovolemic shock. So the same way you need to remember pharmacology for patients in shock. But you're going to apply anesthesia for this patient. And well, you need to remember that we are predisposed, these people are predisposed to
anestésicos locais, então evitar
having
bloqueio
intoxication with local anesthesia. So avoid continuous blockage of these patients. Neural access blockage or general anesthesia, it's a very non-consensual, opinion word, more common sense wins out, and less than
E no mais,
50,000 platelets is not indicated. Also avoid anti-inflammatories. These patients, they already have a noticeable liver damage to overload the liver system even more. You must avoid EM injections. They can generate a lot of bleeding. Non-peripheric blockage must respect the platelet limit as well. About obstetric patients, about patients, when to have neural access anesthesia on these patients, and you're going to assess a number of factors, not limiting itself to the platelet number, but there's a consensus. If you have a typical bleeding, you do not indicate neural access blockage, and there is a certain degree of thrombectomy, and the patient is stable. I'm not going to say that they're well, but they're stable. With a platelet above 70,000, you are authorized. It's very rare that there is a epidural or spinal hematoma is very rare. You need to remember, though, that in dengue, this platelet dysfunction is not just a number, but it is also, there is a reduction in the function of platelets themselves that lasts longer to recuperate than healthy patients, so to speak. Especially also on obstetric patients still, and also on the platelet level, it's important to have a differentiated diagnosis to help symptom. What is in common with these patients? They have the low platelet numbers, fever can happen. Patients then get to emergency C-sec with a in an epidemic, they may have dengue. Remember that HELP does not have pleural occlusion. Dengue does because there is a noticeable plasma leak. HELP does not hematocrates. Dengue does, and HELP it manifests itself as hypertension and hypotension or shock in dengue. But actually, these pressure parameters themselves, they must not be taken as an isolated factor. And also remember the postpartum hemorrhage. Here you can see that we have a lot of serious reports because this is the evidence that we have on the perioperative or here on obstetric patients. So they have the highest risk of having a hemorrhage event, postpartum event. This patient had a fever, 98,000 platelets. So general seizure phase, and this patient lost after removal after birth 3 liters and a half of the surgery, a C-sec that lasted 3.5 hours. So you can imagine what a mess, what a confusion that was. So multiple transfusions. So there, you need to pay a lot of attention to these patients. So after a surgery, the next day, that's when we diagnosed serology of dengue for her. And so I'm going to go into the management of the patient. We can receive these patients in several phases. As we understood already, we will not receive these patients on the A phase, and it will be the most serious patients with risk factor patients or alarming signs, and especially with special attention to serious patients, serious dengue patients. They must be straight to the ICU. They get blood tests every 2 hours. It's very important to have the base hematocrit for this patient because they will serve as a point of comparison for the next ones. Like there's no difference between administering crystalloids or colloids. That's why we have a preference for crystalloids, preferably isotonics. Isotones, we will assess the clinical improvement during this time. We cannot just leave these patients on their own. I'll leave them there for an hour. No, you can't leave these people alone. Remember that these first 24 hours are critical. That's why we call it the critical phase. So patients in shock, compensated shock, says that the patient has low perfusion, but the systolic pressure is normal. So we will manage this with hydration, with more rigorous position. We will assess whether there is a clinical laboratory improvement. We will reduce the infusion. It will pass more and will reduce the infusion. So, and you will collect several hematocrits. If the patient does not have a clinical improvement, you will look at the hematocrit. Did it go up? Then it stays in the bolus. It reduced, the patient is still getting worse. Well, they could have a hidden bleeding. So just keep your eyes open. And on patients that are not improvement, you check, you will go back, revise the hematocrit several times. The patient is in shock with hypotension. They'll have a more vigorous fusion than the one before, and always assessing the hematocrit going back to the earlier stage. This algorithm is cyclic. So after 48 hours, I must interrupt this infusion because the excess of volemic reposition will cause damage on the convalescence phase. Remember that this will absorb the fluids. So it can be a few other complications in the balance. The second important point of management is that it's the bleeding. Why is this light show of blood? Because dengue patients that bleed all over the place. And it's important to remember that dengue bleeding is not just thrombocytopenia, it's multifactorial bleeding, as we saw before. We cannot give out all sorts of hemocomponents for these patients. We need to individualize it case by case. So it's been reported on the use with Zika virus, and not to have these prophylactic infusions. In this study here, where it assessed a randomized controlled study trial, they assessed transfusion versus control and platelets with less than 20,000 plus these patients, they were not actively bleeding, so there's no difference, but it increased the adverse events. So to close this, we go to the really challenging patients, the ones that have anti-aggregants and anticoagulants. They have dengue. And if you really don't care what we do, we suspend all these medications, and then we will correct dysfunction according to the needs, whether it's anti-aggregation, will be platelets, inhibitors, thrombin inhibitors, or anti-10A, minus 10A. We don't have a lot of evidence, but if it's a life-threatening ability, I can use prothrombin complex. Here I have a patient for you, just so you have an idea of the seriousness of these patients. We have patients with several risk factors. This patient went through an angioplasty or acute coronary syndrome. After the first PO, they went to fever. The fourth PO went through hematoma. You can see the hematoma of the patient, and the platelets agreed with a drop to 10,000. Hematocrits were up there. Sorry, actually, they had low hemoglobin. He was actively bleeding, low platelets, hypotension, shock. This patient passed away. So you need to be very careful with patients with dengue and multiple risk factors, especially the ones that go through surgical procedures, even if they're urgent surgical procedures. So how do you act if the patient is not bleeding? Double anti-aggregator. In these patients, we need to balance the risk between avoiding thrombosis, maintain the anti-aggregant, or avoiding bleeding, I avoid bleeding or I avoid thrombosis. You got to choose, either suspend the anti-aggregant or the other one. So this is a guide from the Ministry of Health also, and evidence that does not say exactly that what reference it is, what it said to suspend for these patients with a higher risk of thrombosis. If the platelet has less than 30,000, other sources tell us for 50,000. If the patient has more than 6 months with a stent, a pharmacological or conventional stent, they suspend the AS platelet. It is below 30,000. This is according to the Ministry of Health. So when it comes to Bafferin, it says to suspend platelets below 50 and associating and admitting these patients These patients must be hospitalized so we can verify the platelets daily.
O paciente usando
Patients using
né,
anticoagulants,
como o da bigatrana, rivaroxabana, apixabana,
Ivaroxaban, apixaban,
você tem que esperar
uh,
24
doxaban.
horas
You need to
depois que
wait
ele estiver
24 hours after
suspenso, né,
the
claro,
last
aí espera
use. You
24 horas depois,
suspend,
começa a ponte com heparina e
then it
retorna
goes to
quando os
heparin
platelets
and
forem
goes
maiores do
back
que
when the
50
platelets
mil.
are above
Então, tem lá
50,000.
no Ministério da
So
Saúde é 50 mil, mas em outros
it's
locais é
50,000
100
for
mil,
the
tem
Ministry of
vezes
Health,
que
but in
chega
other
até
places they
100
say
mil.
100,000. So there's no consensus regarding this.
Então, gente, a gente viu aqui
So
vários
everybody,
cenários
we
da
saw
dengue,
several
vários cenários
dengue
de
scenarios,
pacientes cirúrgicos com
several scenarios
dengue,
for surgical
pacientes
patients with dengue
que
risk
procuravam
factors.
com sinais de
You need
alarme.
to be
E
careful
o
what
que que
risk factors and
a World Health
what
Organization
the
diz, né? O que que a OMS
WHO
diz? Que para
shows.
uma doença que tem uma doença complexa, mas que tem um manejo que é
It
relativamente
has a relatively
rápido,
simple,
simples,
cheap,
e
it's
as chances
inexpensive,
são
it's very
reduzidas.
effective in saving lives.
Contanto
As
que
long
nós tenhamos
as
uma
we have
intervenção
an intervention that is timely and
então, aqui
correct.
nosso objetivo
So,
é esse de tentar
this is our goal.
atualizar,
We're trying
né,
to
para poder se preparar para
standardize
esses
things so we
pacientes
can
que
get ready
tem
for these
pacientes que
patients.
geralmente ficam levados
Patients
para o centro
that are
cirúrgico.
generally, they
E aí
arrive
a
at
gente
the
vai
surgery
conhecer
operating room, they're
as
serious
habilidades
state. You need to
paliativas e
recognize the
sinais de
gravity,
alarme
risk
para
factors,
poder guiar os
alarm
pacientes
factors
nesse
to be able
plano
to guide
precoce.
our behavior in an
O
early manner.
manejo ainda é muito negligenciado,
Management is
mas
still very much
podemos, né,
neglected,
podemos
but
ter assim, por isso que
this we can
fundamos
have.
a Bijan
That's why we're here on
para
BJN,
incentivar
for
futuras
us to
pesquisas,
incentivize
boas
future
indicações da
studies,
dengue para
future research to
população
understand
e assim
implications of dengue,
nos
standardize
prevenir de
behavior,
outros feitos
and we can
colaterais.
look for
Muito
improvements
obrigada,
in
me coloco
clinical
aqui à
outcomes. Thank you
disposição
so much.
para
I'm
qualquer
here.
dúvida.
I'm
Então,
available
parabéns
to
também
answer
à
your
Bijan
questions. Congratulations to
pela
BJN
que tem se
for the
projetado, né, de
magazine being
forma
projected
internacional, um
internationally
fator de impacto aí
as an
sócio-americano
impact factor,
inovador na
always
dengue.
improving. It's a great point of pride for us, okay?
Obrigado, Lorena. Parabéns. Excelente
Thank you,
apresentação.
Lorena.
É, o que a
Congratulations.
gente
It's a
vê,
great
na
presentation.
verdade, em relação à
What we
dengue,
see
a gente
really
vê aí
regarding
a
dengue,
gente viu que,
so
por exemplo,
we
no
saw
Maranhão,
here that Maranhão, for
a incidência é
example,
baixa, né?
has a low incidence of dengue
E o que a
this
gente
year,
vê na
for instance.
realidade é
What we
casos
actually
que
see
não são
is
nem
that there are
diagnosticados
cases
na
that they're
cidade.
not even
Então,
diagnosis
quer dizer, é
cases
muita
because they're
gente.
in poor states.
E eu
But we see
tava
we see
vendo
a
aqui
lot of
alguns,
this, and
alguns artigos,
coincidentally,
artigos de
I
jornal
saw a
que
few
saiu esse ano.
articles here,
Esse
journal
ano, a dengue
articles here.
matou mais
This
do que
year,
vocês
dengue killed
nos
more
últimos
than
anos.
the last
Então,
7 years.
foi
So
uma
it's
catástrofe.
a
E eu acho
catastrophe.
que dos sinais que
And I
realmente
think one of the
esse poder
signs
criativo que a
that
Lorena
made us write
trouxe
this
aí para esse
article that
PL, com a
Lorena
Fabiana, com a
headed
Michelle,
here,
com
she
todo
put
mundo,
Liana here as well,
esse aumento exponencial que a gente
this
teve
exponential
da
increase that we
dengue,
have
né? Então, nós
in
chegamos
dengue
vários
cases.
e-mails na SBA perguntando qual
I
o
got several
comportamento dela, por
emails to
exemplo, em
SBA, for
relação
instance, how to behave
ao
relating to
neném.
to a pregnant
E,
woman.
e aí teve a ideia
And
de fazer
well,
esse
we had the
artigo.
idea of writing
Mas uma
this
coisa que eu
article.
vejo muito
Lorena,
é
one
que,
thing that I
às
see a
vezes,
lot
novamente, são os
is
pacientes
that
que não
eventually
chegam, a gente não sabe
patients
se
that
eles têm dengue, como falaram
don't
aí,
know if
pela
they have dengue,
evidência.
we go
Às
for a
vezes o paciente
procedure.
é mal avaliado, suspeita-se de um apendicite, de uma
Maybe you
trombose
suspect
abdominal, e nesse tipo de coisa,
appendicitis or
e
abdominal
depois é
pain,
diagnosticado com dengue. Aí,
and
como
then you
falou aí,
diagnose
esse
them with
seja um dos
dengue.
casos mais
Maybe
desafiadores,
it's one of the
porque
most challenging
a gente
cases
não sabe o que
because
os pacientes têm, às vezes
we
uma
don't know.
apendicite
Sometimes we don't know what they
surge
have.
logo à idade ali no
Maybe
intraoperatório, mas
sometimes
depois o
nothing
diagnóstico
serious
fica cada
happened
vez mais
intraoperative,
pior,
but they may have
os
some
excessos
complication in the
piores
ICU if
desse
things
paciente.
get worse. So,
Com certeza.
for sure,
Eu também fiquei surpresa, né, quando eu vi os
I
relatos
was
para
surprised
servir de alerta para as
when I
nossas
saw the
condutas
reports. So,
diárias,
as an alert
sabendo que nós
for our daily
estamos
conduct,
no
understanding that
período, né, o
we
período
are
de
in a period, this is
emergência, um
the
período
first semester, it's
endêmico
a
de dengue,
endemic,
novembro,
epidemic
e
period.
nós vivemos numa zona endêmica. Então,
We
talvez a gente tenha que
understand
baixar
this.
um pouco o nosso limiar
Maybe we need to
para
lower
lembrar
our
ainda
level to
mais pacientes
remember
com
dengue
eventuais mais
more,
graves, ou mesmo pacientes que estão
especially
jovens, um apendicite,
young
hipotensão,
patients.
mas que estão se comportando de uma maneira
They're
atípica.
behaving in
Então,
an
lembrar
active
dessas
manner,
condutas que
remembering
não
this
são tão
behavior
difíceis
that
assim,
is
por
not so
exemplo,
difficult,
esse extravasamento plasmático, o
or this
tratamento é
plasmatic leakage. The
procedimentoso.
treatment is
Então, ter isso
uh,
em mente e ter uma
replacement for
abordagem
drinking
mais
fluids.
atualizada
So keep in mind the
para poder
standardized
ter que
approach,
selecionar paciente com dengue, sem
recognizing that
dúvida, e
this
talvez
patient
levar
may
o
have dengue,
CTG
and
junto
also
aí, né?
you will change their outcome if you keep that in mind. There's a question from Virginia de Carly. She congratulates you for a presentation. She asks, is there any evidence to test asymptomatic patients candidates for solid organ transplant? A few hospitals adopted this behavior as a routine.
Interessante a pergunta dela.
Well, interesting question.
Então, assim, esse
So
cuidado que a gente tem que
this
tomar com essa
care that we
transplância
have with
é tomado,
transplant patients,
principalmente nesses momentos de
especially in
maior
these moments that are more
desenvolvimento de casos, nós
endemic when an
fazemos
increase of cases.
porque esses pacientes, como eu mostrei aqui, eles chegam assintomáticos para a
So
cirurgia,
patients that get here,
mas
they're
depois
asymptomatic to
desenvolvem
surgery, but
uma
they
doença
develop
grave, né? Eles
a
estão muito
serious
deprimidos
state of illness.
e
They're
acabam
immune
desenvolvendo
depressed and they end up
uma carteira
developing
de anti-infectador.
a
Então,
very
dentro
frightening
dos
state.
artigos que eu
I
busquei
did not
sobre
see in the articles that we looked for, we did not see
uma conduta específica em
any
relação a
specific
esses
behavior
pacientes, mas
regarding
assim,
testing these patients, but seeing the
antígeno, por exemplo,
antigen, for
uma
instance,
sorologia, talvez
or
são
serology, maybe,
ferramentas fáceis,
these
né,
are
e viáveis,
easy
acessíveis
and
e que
accessible
podem ter
measures,
essa
and
preferência.
they can
Mas
really
para esse
make a
caso
difference. So,
específico,
despite
não
not
vai
being
ser
written in the
totalmente válido.
literature, it can be a valid approach.
Vamos ter mais perguntas aqui no
We have no
Q&A.
more questions in the Q&A.
Uma outra questão, Lorena, que a gente vê muito, e eu trabalho em
Another
hospitais
thing that we
públicos,
see a lot, I work in public
depois de
hospitals as well.
maternidade, são os
We
pacientes
see
que
a lot in the
com
maternity ward.
leucopenia, as
Patients with low
transfusões
platelets,
completas de
sometimes
regime de
below the
quimioterapia,
evidence that we
e
have
a
in
gente
literature,
acaba
and we end up
optando, às vezes, pela
sometimes
perda desse
deciding
desfecho,
for
e
neural
dependendo
axis
do tipo de
blockage and
cirurgia for,
detriment of
são
general
escolhas
anesthesia
eventuais que não são as mais adequadas
due to the
possíveis.
eventual conditions that are not the
Acho que
best
pode
possible.
perguntar no teu hospital, como é que vocês encaram isso?
So, and what do you
A
think?
gente percebe que
Ours is the
aqui
same.
ou na anestesia
Uh,
geral dizem
for
que
instance, in
recomendam
Mrs.
a
says they
realização da
say don't
anestesia
delay
com
the use of
sedamento
anesthesia in an
pelo
emergency C-sec
potencial
for the potential
problema que você vê de uma lesão
problem that you
espinhal
see of a
previamente do que
spinal hematoma, which is
realmente tem medo.
much less
A
frequent.
gente tem medo
We're
porque é
afraid
muito
of. We're
grave
afraid because it's
e
very
fala,
serious. But
ele fala explicitamente que acima
we
de
say
70
that
mil é
specifically above
tranquilo,
70,000,
principalmente
it's
70
no
mil é
problem.
pós-anestesia,
And above
abaixo de 50
70,000,
realmente
above
aí tá
below
é
50
como
is
se
where
estivesse em
they're getting
50,
into
mas
trouble.
se os
And
dois
if it's
tiverem
above
uma função
50, but there's
igual,
no
agora eu posso fazer
platelet
uma
dysfunction, you can
reposição de plaquetas
have
nessa
a
paciente e
transcription.
talvez, dependendo do estado geral, mudar essa
Depending on the
conduta,
general state,
sim.
you change this
Nos
behavior. Yeah.
pacientes com dengue, especificamente,
The
estamos
article said
falando de
dengue
duas potências
specifically, not
cardíacas
talking about
síncronas, eles
thrombosis and
optaram por fazer
seriousness itself.
anestesia geral
They
nesses
opted for
pacientes.
general anesthesia
Talvez
for his
elas estejam
patients.
mais,
Maybe they'll
como é
have
que eu posso
more,
falar? Eu usei uma palavra em
how should I
inglês.
say this?
Acaba que elas chegam menos
They end up
com estado geral ruim, então você
in
já percebe
a
uma
worse
certa
state.
gravidade nessas
You can
pacientes
see a
que vão
certain
por LFT
seriousness in
apresentam,
patients, the way they
mesmo com
present
plaquetas de
themselves,
90 mil,
even
70
with
mil, e
platelets
depois
having
essa plaqueta cai
90,000,
rapidamente.
70,000, and then the platelets
Eu
drop
consigo
very
ter
quickly.
uma
No, not every
plaquetinha
service that we
e
have
agora
platelets
receber o
here.
resultado
Get them
aqui
now, and then you
rapidamente
get
no
the
seu
results now.
sistema e em centros de baixo recurso. Mas na dúvida, se você tiver um
But
paciente com
if you have doubts, if you have a
plaquetas
patient that has a fever,
próximo de 70 mil
platelets,
e você ficar
about
mais confortável em
70,000,
fazer uma anestesia geral, também
or
é uma
general
conduta tranquila.
anesthesia, it's
A gente
also
nem chegou a
not
fazer
not that big of an issue.
randomização
So
que a gente
the
fez
accommodation actually,
sugestões baseadas nos conceitos que nós já
based
temos
on the
em
consensus that we
condutas
already
gerais de
have,
dengue, porque na dengue o que nós vimos
dengue,
foram
what we've
7
seen
casos.
was a series of
Quando
cases,
acima de
is that
70
it's
mil,
above
ok,
70,000, it's
mas
fine,
abaixo disso
but
pesaria o
below
risco-benefício, né?
risk benefit.
Doutor André está com a mão levantada.
Dr. Andre has his hand raised. Can you hear me?
Parabéns, Lorena, brilhante
Congratulations,
apresentação,
Lorena.
realmente uma revisão fundamental, super
It's a
importante,
fundamental
vários colegas já
vision.
comentaram aqui. A
Several
minha
colleagues
pergunta
already commented
especificamente sobre
here
dengue severo,
my
né, que
behavior
você
about
colocou
serious dengue.
ali
You
justamente o
put down
editorial, até pela
my
questão do nível de
editorial. Due to
evidência,
the
das
level of
recomendações, não se
evidence, the
posiciona,
recommendation doesn't
né, não
position
consegue
itself.
ainda se posicionar a respeito do
It can't
tempo
position
de
itself
término do
at
quadro
the
clínico
time
para
to a
uma
clinical
cirurgia
trial
eletiva.
for an
E essa
elective
grande questão da
surgery. So
amplitude
the big thing
desse
is
aumento
that
que o Plínio
because of
comentou,
this
foi de
increase
5
that
anos,
Plinio
todos nós estamos pegando
mentioned,
casos de alguns
we're all
pacientes
taking
que
cases of
chegaram
a
de
few
quadro de
patients
dengue
that
severo
have
e se apresentam para uma cirurgia
a serious
oncológica, por
state,
exemplo.
and
Existe
these
uma
present
discussão
for
que os
oncological
colegas
surgery. It's
normalmente, né,
always a
pegam com uma
discussion of,
certa razão, chega o paciente, às
for a
vezes,
certain region,
sem
patients
conhecendo do
get their
quadro clínico, já
convalesce
marca uma cirurgia, você chega
and
com
a
arritmia, com
calls for a surgery, you get these patients that are recovering. So from a practical point of view, we can't write that down in the editorial, but from what you saw,
quadros clínicos virais. No momento que o paciente apresenta uma recuperação, no caso
presents a recovery. For instance, a presented itself recovered in internment. Would we be authorized to proceed for surgery if it was a sensitive surgery, if the stability hemodynamic and improvement of coagulation, even if the clinical frame was maybe a week ago? What do you think? What would be your position in a situation like this one? Good question, Andre. It's $1 million question, you know, but looking at these patients and the surgery, there is a sensitive time for it to be able to be done and to fill out all the release criteria that we showed here. We have the release criteria for dengue, you have a general state,
Se hidratando sem fluidos e
you're hydrating without fluids and they have no fever, even without the use of antibiotics and all this criteria that we showed that is in the editorial, the WHO, I think that we are authorized to perform the surgery and being careful to verify the platelets, how they are they high compared to before? We have all these factors that must be assessed for the system, so I believe that I would perform the surgery. All right, thank you. No, good. Great, thank you. That really is the best behavior, but for certainly there's an increase in morbidity. I imagine that this dilemma and dengue this year really is happening. To complement these cases, I spoke about the clinical cases to show that what goes wrong is when patients have dengue, it's not diagnosed, and there are several risk factors. They go for hydrological surgery, they have a hematoma in that surgery, there is acute kidney lesion, they go towards cardiovascular surgery, they'll have noticeable bleeding. Patients that were not seen before, you know, a fever patient, a few alterations in the blood tests, and they will assess, but if the patient went through all those phases and you assess this patient, it's fine for us to move forward from, especially in this time-sensitive surgeries. Dr. Diego. First off, congratulations, Lorena, for your great presentations. Very good questions. I just wanted to report a case, and we have the area of action have in this hospital, an autumn line in Italy. Unfortunately, she got dengue, and there was an improvement, a substantial improvement. She wanted to go back to Italy. She went back to Italy during the flight. She felt terrible. She stayed a month in Rome. So, because even, I don't know, the planes, they have a pressure, they are compensated, but it's not lower pressure. So it's very interesting. It's unpredictable, and she had a release criteria as well. A simple trip, simple trip. As you said, it's unpredictable, and we need to be extra careful for this high-risk patients. I agree entirely. Oh, we have no further questions. I think that we have 50,000 webinar. I think that I wanted to thank Dr. Lorena for her presentation. I will pass the word to Dr. Andre, our president, to finish our webinar. Thank you so much, all of you. Thank you, Plinio. Thank you. Thank you, Lorena. Great discussion. An honor to have you here. I hope that we can have another webinar in the future. And we'll go flatter you with new opportunities as two more editors, members of the editorial committee contribute a lot to the magazine and also the articles. So it's a great contribution for sure. We'll explore in the future once again the activity. Thankful for the presence of Dr. Diego, participation in our editorial, and special thanks to all our editorial audio colleagues, researchers. You got the news last week of the increase of the impact factor. As we had a higher impact factor, went from 1.3 to 1.7, and it's considered the main metric utilized to measure the impact of the magazine. Metric that we are always attentive to, focusing on quality. There are some criticisms.
Atualmente para medir
metric, but it's the one that we have an article that's replicated in the literature, and that this is a victory of the Brazilian Society of Physiology to finance. So we hope that the magazine will continue to evolve, which is our big focus point for impact, scientific impact of the publications that are done here. And with all this work that is done, the support of now, because of all that we've done with the articles, the webinars, the podcasts, classes that we support, the information that we have in the social networks, and we are able to reach a high public. The information that is published in the magazine or other magazines reaches a Brazilian anesthesiologist that has some sort of behavioral change in the clinical. Thank you so much for all of your attention. So I will see you in the next webinar next month. Peace. Thank you, Andre. Good evening. Good evening, all of you. Thank you. Good evening. Good evening. Thank you. Thank you.